Hospital-based emergency medical services is our episode topic. My guest is Lowell Harden, a registered nurse, paramedic, and fire chief. Lowell holds a National Healthcare Disaster Board certification and is a managing consultant with BRG's Emergency Care Solutions team. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Shimolewski.
Lowell, thank you so much for joining me today.
Happy to be here.
So let's start with some basic questions for review, but we're going to certainly get into more advanced questions pretty quickly. And let's also level set our conversation because EMS practices widely vary from state to state and based on other circumstances like transport times, urban versus rural, things of that nature. We'll cover those assumptions and responses with a general statement of generally speaking, because you should always check your community's specific governing rules and regulations. Does that sound like a reasonable level setting for our conversation today?
It does. There's a wide variety of practices across the country, and you definitely want to be aware of your local and state regulations.
All right. So with that being said, what are the basic functions of EMS and what is hospital-based EMS?
Well, I'll start with a definition. We generally use the term EMS, but that generally stands for Emergency Medical Services or ambulance services as it's more commonly called. And EMS has several functions. The most common is responding to emergency 911 calls. And when the general public looks at EMS, that's what they think. But there's a variety of other responsibilities and responses for EMS. Those include non-emergency transports. They include emergency and non-emergency interfacility transports, event medicine, transporting patients home from the hospital, among others.
And for the purposes of this conversation today, when we're talking about hospital-based EMS, are we talking about pre-hospital transports, facility-to-facility transports, or both?
We will be talking about both, and a lot of it depends on the design of the hospital-based EMS service. But for the purposes of this conversation, we will address both emergency 911 calls and non-emergency transports.
All right. And so when we're talking about professionals that are transporting people in these ambulances, what exactly is the difference between a basic EMT, an advanced EMT, and a paramedic?
Be happy to cover that. There's actually a fourth level that I'll touch on, but they do not typically ride on the ambulance. That's the emergency medical responder who provides first response services. The three different levels that you will typically see on an ambulance is the basic emergency medical technician. And that typically is a 1 to 2 semester course in a local college, and you are licensed or certified with the state, and you can perform basic life-saving maneuvers. Obviously, CPR, you can use AEDs, you can package trauma patients, you can do assessments, you can even administer some basic medications in some states. The second level is the advanced EMT or the EMT advanced, depending on which state you're in. That takes the level of EMT with additional training, and they can do advanced airways, they can administer additional medications, they can start IVs. Then the most advanced person that you will typically find on an ambulance is the paramedic. And the paramedic can do all of the items that an EMT or EMT advanced can do, but they can also defibrillate, they can administer multiple drugs, they can do additional advanced airways, they can do pacing, cardiac pacing. So they're a fully functional EMS provider. There is an additional subset of the paramedic, and that's the critical care paramedic who's gone through additional training. And typically, you will see critical care paramedics on interfacility transfer units. Many times, you will see those on aircraft such as fixed wing or rotor wing or helicopters.
All right, so let's assume for a moment that I'm coming into a role with a new organization as a chief nursing officer, and this organization has a hospital based EMS program. And let's also assume that I don't have any EMS experience whatsoever. What are some key metrics or some key things that I should be looking at to identify and discern whether I have a high functioning hospital based EMS system?
That's a great question. Many CNOs and nurses are used to the hospital staffing productivity measures, and it's different for EMS. One of the first things that you would need to know is what is the function of your EMS? Is it a 911 service or is it a non emergency only service? If it's a 911 service, you will need to know if you have contracts with local government, cities, or counties, and what those contracts stipulate. Because many times those contracts will stipulate the number of available EMS units that must be available at all times, and it will also dictate response times. So, one of the things that the key metric obviously is response time if you're looking at a 911 service. You want to know what the time of call receipt and the time of arrival on the scene and what that time duration is. When you're looking at benchmarking EMS services, typically they use the loaded hour terminology or unit hour utilization. And what that basically means is what percent of the time is there a patient on board the ambulance? And that can give you the utilization. The challenge is that doesn't count your response times to a scene. That also doesn't count the times that you respond to a scene and the patient may refuse or the unit may be canceled. So you have to use the unit hour utilization in combination with your number of responses as well as contractual requirements. The other side of the picture is the non-emergency responses. You can look at loaded patient hours there as well and look at the number of responses. So those are some of the metrics that you can utilize when you're looking to see if you have an efficient EMS service.
Now, what kind of practice issues commonly come up when you're overseeing or leading EMS?
Obviously, it's different with an EMS than it is within the hospital itself because EMS services operate somewhat individually. You have two personnel on an ambulance and they're responding and they're managing a patient without direct visual oversight. And services have to have a medical director. And many services have established protocols that are approved by the medical director that allows them to perform procedures without verbally communicating to the medical director. One of the quality issues is assuring that your EMS personnel are actually following those protocols correctly and that they're not deviating. So it's good to have a quality committee within the EMS service that reviews a certain percentage of the charts, and the medical director should review a certain percentage of the charts to assure that they're following the protocols and also that they're meeting and following within the state regulations.
How do I know if I have quality of care issues in my hospital based EMS program?
Your main way of knowing is looking at the reviews from that quality committee. If you're not looking and you're not reviewing run reports, you're not speaking to your paramedics or your EMTs, it's going to be very hard to know if you have a quality issue. Within your quality committee, there should be certain patients that are reviewed. Every cardiac arrest should be reviewed. Every death while in transport should be reviewed. Your refusals, you should review a percentage of those to make sure that those are being managed appropriately as well.
Okay, let's talk operations and finances, and let's start with supplies. Specifically for hospital based EMS units, what are your thoughts around the supplies, medications, and how those should be handled and restocked?
Part of that is going to depend on local regulations and the hospital itself. But many hospital based EMS services work through the hospital supply chain and they work with the purchasing agents to obtain their supplies. And that works well for 80 to 90% of the supplies you utilize within EMS. But most services have a few supplies that are not utilized anywhere else in the hospital. And the supply chain typically does not want to manage those carve outs, so to speak. So the EMS service themselves typically is responsible for purchasing those specialty type items. The pharmaceuticals, there's typically integration with the hospital pharmacy, and the pharmacists oversee those medications. They supply the medications to the EMS service. Of course, there's a process of validating and double checking and making sure the medications are secure and maintained and utilized appropriately.
In terms of transport times, are there standards out there about response times and expectations?
I would say standards for this purpose may be a looser term than we would like. A lot of it's going to depend on the organization, the region, the geography. If you're looking at a city based EMS services that's responding within the confines of an established city, many times there are contractual standards, and those can vary widely, but some range from 5 to 10 minutes, with 10 being fairly common within a city limits. When you look at rural based EMS, that's a very broad topic. A lot of it's based on population, it's based on how many ambulance bases or ambulance stations you have throughout the county. So in some cases, you could have a 45-minute response time if it's very rural.
Along with that, where should hospital based EMS units, pun intended here, be actually based? Should there be a station attached to the hospital, or should they be out in the community, or you have multiple units that are spread around? I mean, what should that look like?
That's an age old question that's debated almost every day somewhere across the country. And I will say first, it depends on the structure and the responsibility of your EMS service. If it is a non emergency service only, they could be based anywhere, and many of them are based at the hospital. If you are providing 911 emergency response services, then you need to look at the distribution of your 911 calls. And you very well could have a base at the hospital, but you should also have stations dispersed throughout the coverage area based on the volume of calls. This also leads into the question, should EMS personnel be helping out in the hospital when they're not responding on emergency runs? And there are pros and cons to that situation. One, it allows hospital to use personnel if they're not busy to assist. On the other hand, those personnel have to be able to drop immediately and respond to emergency calls. So from my perspective, a mix can be appropriate depending on the call volume of the EMS service, but those services have to be immediately able to respond. And you also have to remember that some of these services work 24-hour shifts. And when that occurs, you can't have that EMS crew awake and working the full 24 hours.
So if you do that, would you, like, if you're helping out, let's say in the emergency department for a 2-hour time in which there's no runs or no calls, do you transfer the hours from one cost center to another?
Typically within the hospital, obviously, when you float staff, you do transfer those hours. And you could argue that these hours should be transferred. But when you're going back and you're reviewing your annual budget and you prepare for next year's budget, finance typically looks at the number of worked hours. So if you are transferring those calls out of the EMS service to another department within the hospital, and finance says, oh, you did this last year with X number of hours, so you only need this number of hours this coming year, it can skew your upcoming budget.
Not only that, if your calls go up, then you have a problem because you're not adequately staffed potentially.
That is correct.
All right. So what does revenue look like for hospital-based EMS? You mentioned the concept of loaded time or loaded minutes or hours earlier. Is it based on that? And how does that equate, or does it equate to productivity itself?
So it does equate to loaded hours. Most EMS services in most states only get reimbursed for patient transports. So they don't get reimbursed for our response to the scene. They don't get reimbursed for care on the scene if the patient's not transported, and they don't get reimbursed if they're canceled or if the patient refused. So you only get reimbursement if you transport the patient. And then the reimbursement from that is based on the level of care provided. You have a variety of levels of care, BLS 1, BLS 2, ALS 1, ALS 2, and that all equates to the level of care and what you're actually doing for the patient. And then you also have specialty reimbursements for specialty care transports as well.
A lot of nursing leaders are trying to manage throughput in their hospital, and getting patients out is one of those challenges. I would assume that the non-emergency billing code pays less than the emergency billing code, and if that is an accurate statement, I'm just trying to understand how prioritization would work. Because one of the things you want to do is bring new patients in, but at the same point in time, you got to have space for them, and so you need to get other patients out, which is actually less revenue producing. So how does that prioritization work, both from a revenue perspective and frankly also from a quality perspective as well? Getting patients to emergency care is more important than getting a patient that is ready to be discharged out. So help me understand how to negotiate that to keep the flow going and also make sure patients are getting the access that they need.
Sure. And I'm going to restate something I stated earlier. It's going to depend on the setup of your EMS service. If you've got a service that basically has one division that runs both emergency calls and basic life support transfers, then you are going to have a challenge and there's always going to be a balance. If you're running emergency calls, those non emergency transfers or discharges are going to just wait. If you have a larger service and you have the ability, I recommend having a service that is subdivided into your emergency response portion of the service and your non emergency transport portion of the service. That means that certain units and certain personnel are designated for 911 calls, and then other units and other personnel are dedicated to the non emergency transport side. And that eliminates some of the conflict that you referred to, both from a personnel and a staffing perspective, as well as a reimbursement perspective. Your BLS transfers, many times you don't have to have a paramedic on the truck, so you can use personnel that don't cost the organization as much. And you also have units that are dedicated to those non-emergency responses. That being said, there needs to be good collaboration between the hospital and EMS service. The inpatient personnel can't expect to call in 5 discharges within 10 minutes and have units show up within 30 minutes for all 5 of those discharges. From a staffing perspective, that's not always realistic. So pre-planning, working with discharge planners, case managers, social workers, anticipating discharges a day ahead of time, collaborating with the EMS service to let them know how many discharges are anticipated, the time of day they're anticipated. That collaboration can help smooth that process.
Great. Let's shift gears a moment and talk about staffing and scheduling. In your experience, what is the right skill mix of professionals on the different types of EMS transports? You mentioned earlier basic, advanced, paramedics, and then the critical care transports, but there's also nurses that sometimes transport on those critical transports and even physicians. So, what's the right mix depending upon the type of transport you're doing?
That's a great question. And I'll start with what I consider the lowest level of transport that is used by some EMS services, and that's the wheelchair van. That can be staffed with one person. And in many states, that doesn't even have to be an EMT. That can be somebody that's trained in CPR and basic first aid. Then you move up to the basic life support unit, and that's typically staffed by 2 EMTs that can provide basic life support and carry a person that requires any basic life support needs. Then you advance to the advanced life support, and this can be for non emergency or emergency responses. And that's typically staffed with at least one paramedic, sometimes two, but either an EMT or an advanced EMT. And that unit is able to provide advanced life support from an emergency response standpoint, or if there's an advanced life support interfacility transfer, they can manage many of those. Then the next level is a specialty care transport unit that does typically interfacility transfers. Those typically have a paramedic. Many times that paramedic is a critical care certified paramedic. They have an EMT that's driving the unit. And then those units vary beyond that. Some of those are staffed additionally with a nurse who may also be an EMT. They may be staffed with a respiratory therapist. And in some cases, they're staffed by a physician or a resident. Moving up beyond that, then you actually have the air transport, such as the helicopters, is the most typical that we think of. The typical staffing of a helicopter is a pilot and a nurse and a paramedic. And the nurse in most states is required to also be at least an EMT basic. You have some variations of that. Some organizations will replace the paramedic with a respiratory therapist and have a nurse respiratory therapist combination. And then some organizations will also use a physician or a resident on the helicopter transports as well.
And what are specialty services transports and how do you appropriately resource that?
There's a variety of different types of specialty transports. Bariatrics is a specialty transport. You may not need specially licensed people, but you're going to need special equipment that's designed to manage bariatric patients. Then you have, for example, pediatric transport units or neonatal transport units, which can have nurses and respiratory therapists and sometimes paramedics that are specially trained in the management of those neonates and those pediatric patients. A lot of children's hospitals have these units. So if they have a transfer coming in, they will actually send the transport unit to the outlying hospital. You also have stroke units that may respond. Some of those have an onboard CT scanner. And then you may have cardiac specialty transport. So there's a wide range of specialty type transport units.
Let's transition topics again and start talking about our collaboration with EMS units. Are there any key pearls of wisdom in collaborating with EMS colleagues, both from a discharge transport side as well as on the pre-hospital ED side?
In short, yes. And first, it's true with any organization or any organizations that are working together, and that's to build relationships. The time to develop a relationship is not at the time of call. So the EMS leadership and the inpatient leadership should have a very close relationship. There should be regular meetings. In fact, I recommend at least a quarterly EMS meeting with emergency department leaders, possibly inpatient leaders, and including all of the EMS services in the area to talk about processes, to talk about expectations, to talk about challenges. And if you have those relationships ahead of time, if you build expectations ahead of time, then if there is an issue, number one, you know the person to call to resolve. And number two, if you anticipate those issues ahead of time, you can have processes in place to prevent those issues from occurring.
One hot topic in some communities is the concept of wall time and or offload times in the emergency department. What exactly is that?
Wall time has been a problem in certain portions of the country for years, and in recent years, it's become a more widespread issue. And wall time is defined as the time the EMS unit arrives at the hospital until the time the patient is turned over to the care of the personnel at the emergency department. Typically, you want that to be a very fast process, but in some parts of the country, you will have 3 and 4 hour wall times. And so the paramedics are still taking care of the patient on their stretcher in the hallway, waiting for the care to be turned over to the ED staff. And this is a challenge because it impacts the care of the patient. It impacts the availability of the ambulance service to respond to another emergency. And it can create friction between EMS and the ED staff, and obviously between the patient and the ED staff. So hospitals should work diligently to maximize or minimize the time those patients are on wall time. They can enact protocols, they can enact processes so those patients can be evaluated. If the patient is not extremely ill, they can offload them to a waiting area to where they can be managed or evaluated by ED staff.
Now, does wall time count towards that loaded time for revenue, or does it equate to lost productivity?
It equates to lost productivity. It does not impact the revenue generation.
Any closing thoughts?
EMS services are very important to a community. Hospital-based EMS services have the ability to collaborate and work very closely with the hospital, maximize the care of the patient, minimize interruptions in care, and pre-planning and collaboration leads to excellent patient care.
Lowell, thank you so much for taking the time to speak with me today and discuss all things hospital-based EMS.
Thanks, Nick. Appreciate the opportunity.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.